I am telling you one story of mine of 2020-2021. At that time, I was posted in COVID ICU for almost like 4 or 5 months. It was continuous, and at that time I found many complications of this COVID, and among them one I would like to talk today, called thrombotic microangiopathy. Yes, thrombotic microangiopathic hemolytic anemia can also occur due to COVID, and we saw many cases. We also saw cases of DIC with COVID. I cannot remember exactly how many cases I saw, but good number of cases I saw. So they used to have hemolysis, haptoglobin low, haptoglobin, increased LDH, decreased hemoglobin, thrombocytopenia, PT-INR is normal, vitamin B12 is normal, and creatinine is 1.82, like that. So when we see like this type of picture, we think like possibilities include disseminated intravascular coagulation or TMA, but since PT-INR is normal, it favors more towards thrombotic microangiopathy. And one important point regarding thrombotic microangiopathy is that it has high mortality. I do not remember exactly what is the mortality, but let's say it is about 90% mortality if you don't do plasma exchange. But if you do plasma exchange, mortality decreases by 90%. That effective is the plasma exchange. So plasma exchange is most essential in this case. That's why we need to recognize whether it is TMA, thrombotic microangiopathy, or not. And once we suspect clinically, we do not wait for ADAM-TS13 level, we directly order plasma exchange. So why TMA occurs in some viral infections, some bacterial infections, like in Streptococcus pneumonia, it can also occur TMA, or COVID, or cytomegalovirus, influenza. In these conditions also thrombotic microangiopathy occurs. So in this condition, what happens that there is a small thrombus in a small vessels. That's why we call microangiopathy. Micro means small vessels, there are a small thrombus. So in brain it can occur, or in capillaries, arterioles, that is supplying the bowel, there it can occur. In the kidney it can occur. In the coronary circulation it can occur. So in multiple places these small capillaries can get thrombosed, and it can cause infarction to the distal organ. And depending upon that, patient can have symptoms, like if the vessels in the brain are blocked, then patient can have encephalopathy, infarct, ischemia. If heart circulation is thrombosed, it can have angina, myocardial infarction. Or if GI circulation is blocked, patient can have diarrhea, belly pain, ischemic bowel. So depending upon where is that thrombosis, patient can have varied manifestations. And this is a systemic process. Systemic means any organ can be affected, brain, GI, heart, any kidney, anywhere it can get blocked, circulation can get blocked. That's why timely plasma exchange is essential. And this is a temporary process. Temporary means, like, infection does not last longer time, like it resolves in like a week or 2 weeks, most of the infections. So during that time period we have to support, we have to clear the antibody that is present in the plasma with plasma exchange. Plasma exchange filters all those antibody against ADAM-TS13 and replaces normal plasma. So this is temporary support till infection gets handled by our immune system, or with the antibiotic if it is bacterial infections. But in viral infections we do not have much drug, but whatever we have to manage with those antivirals. So basically the thing is that we have to do support with plasma exchange temporarily till infection gets cured. Like I saw one patient who got renal transplant recently, and after that she started developing hemolytic anemia, thrombocytopenia, encephalopathy, abdominal pain, diarrhea, nausea, vomiting. So the picture was typical of thrombotic microangiopathy. So we initiated on plasma exchange, and after 2 cycles of plasma exchange, her thrombocytopenia improved. Like today I saw her platelet was 145,000. Initially it was like 30,000, but after plasma exchange it improved remarkably. So plasma exchange saves lives. So we have to recognize TMA in timely manner. And in the previous days, in 1900s, when we do not have diagnosis of this TMA, people discovered TMA after like 1920s, 1920 I think. Before that they did not used to know what is this, what is going on. Like people used to die after with elevated creatinine and encephalopathy, and they used to do autopsy and they used to find there are thrombus in the brain, thrombus in the bowel, thrombus in the kidney, and they did not used to recognize why is it occurring. But later they found that in this antibody forms again ADAMTS13, and ADAMTS13 is an enzyme which cleaves the von Willebrand factor multimers. But if antibody forms against that enzyme, this cannot chop up the von Willebrand factor multimers, and due to that thrombosis occurs in multiple organs.